Well, here we are talking about somatic symptom and dissociative disorders. And normally, I feel like this, in other semesters, this has only been about half a class's worth of material. But because of the way this semester panned out in terms of how many class meeting dates we had and the lack of a midterm exam and the lack of oral presentations, which I know those two factors are really, really bumming you out. I know you wish you had a midterm, and I know you wish you had to do an oral presentation. I'm able to devote one whole class to this, but I haven't actually changed the content. So this might be a little bit of a shorter one. I'm sure you're going to be horribly disappointed by that, but it might not be. We'll see. Once I get started talking, you never know what's going to happen. So I know a couple of you indicated on those first class info sheets that you were really interested in learning about these disorders. Which is great, and I'm super excited about that. But now I'm going to disappoint you a little bit by telling you we're not going to spend a ton of time and go into a ton of depth, in large part because these are exceedingly rare disorders. They're fascinating, and it seems like every soap opera writer is well versed in these disorders, because as we go through the disorders, they'll be like, oh, I've seen that in like that, and I've seen that in Days, and I've seen that in this, and I don't even know what soap operas other than Days of Your Life are still on TV, and I only know that's still on TV because I have like a couple of friends who still actually watch it, and I'm like, well, who watches soap operas anymore? But in real life, particularly the dissociative disorders are quite rare. The somatic disorders a little bit less so in terms of rarity, but also something you're not likely to encounter clinically the way you're going to encounter depression, anxiety, substance use, eating disorders, suicide, post-traumatic stress disorder, things like that. So I think it's important that you have some knowledge about it, but I also don't feel like it's something that we need to go into a whole ton of depth on. Certainly, if you're interested, you can do some more reading on your own or reach out to me and I can point you in that direction. The somatic symptom and dissociative disorders used to be thought of as neuroses, particularly the somatic symptom disorders. And of course, we think like, well, that's not really a nice thing to say, like, oh, your diagnosis is you're neurotic. And we, of course, use neuroses and neurotic in our everyday language in a different way than what was intended clinically. But these are disorders that are thought to be linked to anxiety, but understood now to be their own set of disorders, but they are thought to be likely triggered by stressful experiences. And that's true for both the somatic symptom and the dissociative disorders. They're two different disorder classes, so to speak. And so just to start with an overview of what they are, when we're talking about somatic symptom disorder itself, so this is where it gets a little confusing because somatic symptom and related disorders is one category, but somatic symptom disorder is one specific disorder in that category. However, let me just sort of run through this and then explain things a little further. So it's a disorder involving extreme and long-lasting focus on multiple physical symptoms for which no medical cause is evident. And while that is the description for somatic symptom disorder itself, there is an element of physical symptoms for which there's no medical cause for all of the somatic symptom disorders. So that's why it's sort of one of those weird, I'm sort of defining the one disorder, but at the same time defining all the disorders at the same time. Somatic symptom disorder itself was formerly known as somatization disorder. The name was changed in DSM-5. I think somatization disorder makes it sound a little bit more stigma-y and a little bit more like the person is creating the disorder when that's not really what's happening. And then dissociative disorders, so the whole group of dissociative disorders, are disorders in which individuals feel detached from themselves or their surroundings, and reality, experience, and identity may disintegrate. So those are disorders in which the normal integration of consciousness, memory, or identity is suddenly and temporarily altered. So the dissociative disorders in particular make for really compelling TV drama or movie drama. So we see that a lot more in media than what actually exists in real life. So let's take a look at our somatic symptom and related disorders. If we were in class, I would tell you right now, don't write this slide down. And I don't really feel like I need to say that because you have PowerPoint slides with this. This is just an overview of what the different somatic disorders are. So we have somatic symptom disorder itself, illness anxiety disorder, which used to be known as hypochondriasis, psychological factors affecting a medical condition, and conversion disorder or functional neurological symptom disorder. Okay, and then closely related disorders to the somatic symptom disorders are malingering and factitious disorders. Before DSM-5, we had some additional diagnoses as well. So we had pain disorder. So that was where the focus was on pain that didn't have a medical cause. That disorder has now been sort of subsumed into the somatic symptom disorder. Body dysmorphic disorder used to be listed as a somatoform disorder. That has now been moved to the obsessive compulsive and related disorders. Hypochondriasis, which was renamed illness anxiety disorder. Conversion disorder, which remains but also has the additional more descriptive name of functional neurological symptom disorder, and then somatization disorder, which has been renamed somatic symptom disorder. And so again, we're going to sort of go through each of these in turn in a little bit of detail, and then we will switch over to our dissociative disorders. So for somatic symptom disorder itself, the main features of the diagnostic criteria are that the person has one or more somatic symptom that is or are distressing, and the person experiences excessive thoughts, feelings, and behaviors related to the symptom or symptoms, and it's been going on for at least 6 months. So in the old criteria, it was really strict symptom requirements, like it had to be 1 pain system, 2 gastrointestinal symptoms, 1 neurological symptom, 1 sexual symptom, right? And it had to be causing distress and impairment. It had to be going on for over 6 months. And finally, what the community, and when I say the community, I mean the psychiatric and psychological and medical communities realized was you don't have to have people check all the boxes. The disorder is just as real if they only have 1 symptom, but they're thinking about it all the time and they're behaving in ways to deal with it all the time or to seek clarity around it, and it's been there for at least 6 months. There's no difference clinically between somebody with all of these ticky boxes and only the 1 ticky box, and in fact, by having the disorder have the 1 pain and the 2 GI and the sexual and the neurological symptom, it was harder to capture people and recognize that it was a somatic symptom disorder that they were experiencing, because each symptom had to last over 6 months, and you could see a person going to see their family doctor with these vague complaints but spread out over years. It would be very hard to put it together, right? So what happens for a person with somatic symptom disorder is they have a symptom, but the way they deal with it and the way they think about it is far different from the way most of us would. So most of us, if we realize that I've got some knee pain, right? Like I did this weird thing when I was playing tennis and I went to get a shot and my leg kind of slid out from under me and my knee swelled up and it still hurts. Like I did all the right things. I rested it, I used ice, I elevated it, I took, ibuprofen to try to get the swelling down. But it's been a couple weeks and it's still bothering me. Most of us would then, make a doctor's appointment, seek out a medical opinion, does it need to be imaged? Do I need any additional treatment? Do I just give it time? And then we would follow our doctor's recommendation and hopefully our knee would heal and we'd move on. Someone with somatic symptom disorder is going to do all that, except they're not going to get better, right? So the we heal up and then we move on, they're going to still have something that isn't quite right. And they're going to go back to their doctor. And their doctor's going to say, well, objectively, it looks like it's okay. And you're going to say, well, but it's really not. I'm still experiencing, I wake up at night, sometimes it's so painful. Your doctor's thinking, okay, well, let's run a new set of imaging, let's see. And so they send you for, this time for an MRI. Last time you just had x-rays, but now they want to really see what's going on. MRI comes back, there's very minimal damage to the knee. You shouldn't be experiencing the levels of pain you're experiencing. And so you go off on your merry little way, but like it's still, like, you know, like it just doesn't feel like it's quite back to normal. And so again, another doctor's visit. And then you get frustrated and say, I really think you should refer me to an orthopedic specialist. And your doctor at this point is fed up with you and is like, okay, fine. You want to go see an ortho? Great. Because your doctor's also thinking like, orthos like to cut. That's what they do. They're surgeons. Have at her. And you go see an orthopedic surgeon who says, actually, like, I like doing surgery and you're non-surgical. There's just really nothing all that wrong. There's really nothing I can do for you. But you still are thinking about this and thinking that your knee isn't 100% better, and now you're starting to engage in behavior. So your tennis partner is like, hey, so you ready to go play again? You're like, oh no, I can't possibly ever play tennis again because my knee still hurts. And then your tennis partner's like, okay, well, why don't we go for a walk instead? And so you go for a walk and then you're like, oh no, you know what? I gotta stop, my knee really hurts. So your behaviors are all around this knee pain. You're continuing to seek out care. You're thinking about it a lot, but there's nothing actually still wrong physically. Hopefully I'm like looking at Ian thinking like, does that make sense? But he doesn't have to answer that. So hopefully it makes sense to you guys. Ian is entertained by me, I think. He's nodding his head yes. Okay. And so when we diagnose it, we specify whether it's with predominant pain and whether it's persistent, mild, moderate, or severe. So those are just the specifiers that go along with it. As you can imagine, it's with only needing to have one or more symptoms, it is potentially a little bit easier at some point for a physician to say, okay, listen, we've done all the tests, we've done all the treatment. Objectively, you should be better by now. You're not. Maybe it's time to talk to a psychologist, to which the person says, well, I'm not crazy. I don't need to talk to a shrink. Okay, first of all, we're not shrinks. That's the term for psychiatrists. Psychologists are just psychologists. We're just people. We have feelings too. But people don't really tend to like that because they feel like, I have something physical going on. Why are you sending me to a psychologist? In the past, with all of those different levels of symptoms that someone had to have, it could take years before a doctor was like, you know what, like I'm tapped out. Go talk to the psychologist. People with somatic symptom disorder will also doctor shop to some extent. If they're not satisfied with what they're getting from their doctor, they will go to another one. They will look for another one. They'll go to, their doctor won't give them a referral to another sports medicine specialist. They'll go to a walk-in clinic and see someone there to try to get it. So they will continue. With with electronic medical records, it's getting harder for people to doctor shop in that way because you can see that this person has had 4 doctor's visits already to 3 different doctors about this issue, and another doctor might be like, listen, you've already seen 3 people, like we're done here. But psychologists can help, potentially, if a person is willing to go. A lot of people with somatic symptom disorder really do not appreciate the suggestion that there's a psychological component because to them it is very real and they will resist seeing a psychologist. Other people who aren't such big fans of psychologists are people with illness anxiety disorder. So again, illness anxiety disorder is what used to be termed hypochondriasis. Again, we use the term hypochondriac in our everyday language in a way that is quite different from the clinical intent. So DSM-5 changed the name of the disorder to illness anxiety disorder, because of the overuse of hypochondriac in everyday language, and also because they thought it gave a better description of the disorder itself. And so what this basically is the anxiety around the possibility of having a serious medical illness. So, we all get headaches from time to time. And what do we do when we get a headache? Well, take some Tylenol or Advil, drink some water, drink some coffee, because caffeine can actually help with headaches. For people with longer hair, take out our ponytail holder that might be causing, right? Because we might have pulled our hair too tight. It's kind of like this game. You have a headache. Is it because you're tired? Is it because you're dehydrated? Is it because you've had too much caffeine? Have you had not enough caffeine? Is your ponytail too tight? Did you sleep funny? Or is it a brain tumor? Ding, 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 ding. That's the one the person with illness anxiety disorder loops onto. So that was the 7th possibility for this headache. Oh, I guess I can also add, is it COVID? Because a headache is a symptom of COVID-19 as well. But I see that one doesn't really even enter for me because there's so many. You stub your toe, you have pain in your foot, could be COVID. Anyway, let's go back to illness anxiety disorder. Let's go back to the brain tumor. Most of us, most of the time, if not all of the time that we get a headache, we're like, it's a headache. Oh, the other thing, drinking. Yeah, too much of that the next morning, bad headache, right? So we don't go to brain tumor, but the person with illness anxiety does. So they have a headache, and it's a bad headache, and they took some ibuprofen, and it actually helped, and the headache went away, but they don't usually get headaches that are that bad. So it's got to be a brain tumor. And so they go to see their family doctor, and their family doctor says, what brings you in today? It's like, well, I had this really bad headache the other day. And the doctor goes, okay, well, tell me more about it. Well, it was really bad. It was just, it really startled me. It was quite painful. And so I got concerned about it and wanted to make an appointment to see you. And the doctor says, okay, that's fair. There could be a bunch of contributing factors to why you had a headache. So why don't we run through? And so they'll check, okay, no, your blood pressure's perfect, so it probably wasn't like a blood pressure, like was there anything really stressful that just happened? Nope, it just sort of came out of the blue. Okay, well, what did you do? Well, I took some Advil, I drank some water, had a little nap, and then it went away. Okay, so it sounds like it was just a headache, right? So like, why are you here? Well, because I just, it was so bad, and even though it responded to what I tried, I'm just worried there's something else there. Doctor says, like, oh, okay, fair. Like, let's check things out. Checks the person out, says, like, I see no reason for this to be a concern. It sounds like it was a bad headache, I'll give you that, but like, there's nothing indicating you're not showing any signs of having had a stroke, your blood pressure's fine, your heart rate, like it doesn't seem to be cardiovascularly induced. It was probably just a headache. And the person with illness anxiety disorder goes, probably. But what if it wasn't? And the doctor goes, oh, it's possible. Why don't we just keep an eye on things, right? How about for the next month, keep a log of any headaches you have, right? Keep a headache diary. And the person goes, okay. So over the next month, they're like vigilant. It's like every morning they do like headache check, right? Like any sign of headache, oh, there's a little twinge, right? Like there's a little headache going on. They write down in their little headache diary. And at the end of the month, they go back and see their doctor and they're like, look at how many headaches I had. Which of course, if they hadn't already glommed onto the idea that the headaches were a problem, they would have missed 97% of them because they were really quite minor. So, okay. The doctor says, well, that's actually a fair number of headaches. Okay. Let's send you off to a neurologist for a neurology assessment. Let's just be, like, I still think it's just headaches, but you know what? Let's go ahead and pursue it further. So, person waits 7 months. They finally get their appointment with the neurologist. In the meantime, they've been keeping this headache journal, which is now into its 2nd volume. It's getting ready for a 3rd printing, right? It's just really going on and on and on. And the neurologist says, it sounds like it was just a really bad headache. And then you became so conscious of it that you kept noticing more and more headaches. And the person says, well, yeah, that's a possibility, but like, is there a chance that it's something else? And the neurologist says, well, of course there's a chance. I mean, it could be. And the neurologist lists off a whole bunch of conditions. The person goes, aha, I knew it was a brain tumor. And the neurologist is like, wait, what? Like, I just said it could be any one of like 17 different things. How did you just, okay. So finally, the neurologist is like, how do I get this person out of my office? You know what? Let's send you for for a CT scan. Let's see what's going on. Person's like, okay, now we're getting somewhere, right? That CT is for sure going to show my brain tumor. So another 3 months go by. They have their CT. They go back for their follow-up with the neurologist who says, CT was clear. No abnormalities whatsoever. Person with illness anxiety disorder says, well, but that's just like a static image. Don't you think you should have ordered an MRI instead to get more of a functional picture? Like Maybe, it's not, and so the neurologist, once again, is like, this is not a good use of public health dollars, but okay, fine. Writes the requisition for an MRI. 6 months later, after the MRI, goes back to the neurologist and says, okay, the MRI is perfectly clear. Like, there is nothing there. Yeah, but I think I moved. They told me to lie really still, but I think I moved. And maybe I jostled my brain just enough that somehow the tumor was absorbed and it didn't show. Maybe we should do another one. And the neurologist at this point is like, maybe we should be thinking about a psychiatrist at this point. But the person with illness anxiety disorder is so convinced that they have a brain tumor that if this neurologist says, listen, all of the functional tests I've done with you are within normal limits, your CT was clear, your MRI is clear, I'm discharging you as a patient because there's nothing here. So goes back to their family doctor and says, that neurologist didn't listen to me at all. They said they ordered these tests and I went and did them, but I'm still having these headaches and I'm still really profoundly certain that there's something wrong. Can we get a second opinion? The family doctor's like, yeah, what else? Just so I don't have to deal, I don't know how to make you realize that there's nothing wrong with you. Sure. And so the person remains convinced that this one bad headache is a brain tumor. And despite all the medical evidence to the contrary, they remain convinced and have tremendous anxiety around having a serious medical illness. Okay, that's fun. Psychological factors affecting a medical condition. This happens, we sometimes have a psychological influence that impacts a diagnosed medical condition, so things like migraine headaches, which are very much a medical condition, but are very much sometimes triggered by stress. They also can be triggered by red wine, they can be triggered by weather changes, they can be triggered by allergens, but it can certainly also be triggered by stress. People who have asthma can end up having an asthma attack triggered by anxiety, right? So we have medical conditions that are then affected by psychological factors. So that's another piece that we do consider in the somatic symptom and related disorders. This takes us to reflection question number 1. Which term, hypochondriasis or illness anxiety, do you think better captures the concept of having anxiety around the possibility of having a serious medical illness, and why? Okay, so let's move on and talk about conversion disorder, or what is also known as functional neurological symptom disorder. Now, conversion disorder was originally, way back in the way back time machine, known as hysteria. And it was, of course, Papa Freud who came up with that. It was Freud who coined the term conversion. He thought that anxiety and psychological conflict converted into a physical symptom. And so what we're talking about with conversion disorder is one or more symptoms of altered voluntary motor or sensory function. Okay, so things like paralysis with no physical cause, or anesthesia, so like a loss of sensation or vision loss. So imagine, if you will, that you wake up one morning, and actually let me just start my next point, there's no medical cause for it. So that's the other thing, there's no medical cause. And this is also the example where I have to be careful, because I'll tell you a story about why I have to be careful with this example when we get there in the example. You wake up one morning and you cannot see. So normally in the morning, I open my eyes, I can see things. Even if it's really dark, I can then feel for something, usually my phone, which then the screen lights up and boom, okay, I can see things, right? So imagine you wake up in the morning, you open your eyes, you can feel yourself opening your eyes, and you see nothing but darkness. You might be like, okay, wait, am I really awake? Is this some weird, weird thing? Maybe I dreamt that I woke up. Maybe let me try opening my eyes again. And so you open your eyes again, you still, nothing but darkness. So now you're like, okay, let me pinch myself. Oh yeah, I feel that. Okay, I'm awake. So if you live with other people, whether it's a partner, a roommate, parents, siblings, child, anybody, the first thing you might do is put your hands on your eyes to be like, okay, who taped my eyes shut, right? Like looking for the piece of tape that's covering your eyes. but there's nothing there. You're feeling, right, just like I'm doing now, and you're like, okay, no, those really are, I know my hands are clean because Lord knows I've sanitized them enough times, so touching my eyes, nothing. But after saying that, I'll just sanitize my hands again, just, because I just touched my face, and really, who does that these days? Okay, so there's nothing covering my eyes. So now, like, holy shit, I'm blind. Like, what the hell happened? Like, I went to sleep and now I can't see? So now's the time where you say to someone else who lives with you, hey, I think I have to go to the hospital. And your partner, friend, spouse, roommate, parent, sibling, child, whoever says, why? And you're like, I can't see. And they're like, oh, like, that is weird. Yeah, okay, that seems like that's worth a trip to the emergency room, right? Now, if you live alone, the thing that you do is you say to the voice-activated software on your phone, and this is the funny part. I did this in class once, the first time I did this in class, where I said, hey, name of the voice-activated software on my iPhone, call the 3 numbers that begin with 9 and then there's 2 1s. And the voice-activated software on my phone replied saying, calling the 3 9. I was like, oh my God, I don't need to call that over. So I'm very cognizant now when I keep looking at my phone to make sure the screen isn't lighting up, that I do not say the name of my voice-activated software, and I try not to say that 3-digit number in such a way that my phone might be like, oh, Carrie's in trouble, she needs help. Because yes, so what I learned is you have 5 seconds to stop the phone from actually calling emergency services. Because I cannot imagine that call with the dispatcher being like, what's the problem? The problem is I'm an incompetent professor, right? And I don't really understand technology, but thanks so much. This was just an example in class. So again, if you live alone, the good news is you can't see, your voice-activated software will take care of you. I can assure you of that. Okay, so you go to the hospital, you're at the emergency room, and the triage nurse is like, what seems to be the problem? And you're like, I can't see. And they're like, huh. And so they whip out their little pen light, and you're like, your eyes are tracking, but you're like, I can't see anything. And they're like, really? Yeah. So then you see one of the emergency room doctors who goes, this is like an ophthalmology problem. So they call the ophthalmology resident. He's like, oh, this is weird. And then they get like the ophthalmology attending. And in the meantime, you can't see, and nobody is coming up with a reason for why you can't see. So they might at some point eventually get a neurologist on board, but ultimately what they determine is there is absolutely no reason that you cannot see. Your eyes respond, right? So your eyes respond to them shining a light at you, all that stuff, but you cannot see it. That is conversion disorder. Okay, in terms of closely related disorders, we have malingering. And malingering is basically a fancy way of saying faking. So malingering, of course, is not a mental disorder. So again, we're using the diagnostic categories from the Diagnostic Manual of Mental Disorder, Diagnostic and Statistical Manual of Mental Disorders, 5th edition. But malingering is something that happens often, and it gets talked about in the context of the somatic symptom and related disorders because that's where it would sort of best fit. And typically malingering happens when somebody has been ill or has been injured, and they have been getting some sort of benefit. So whether it's unemployment, whether it's disability benefit, whether it was moving back in with someone who's taking care of them, whether it's all their friends being extra nice to them because they've been ill or they've been disabled, and they go, hey, I kind of liked that. I don't want to go back to work, or I don't want to go back to having to take my own notes in class, or I don't want to have to take care of myself. So they continue to fake the symptoms that they had, even though they have in fact recovered. So people don't often malinger from out of nowhere. Some do. I mean, it does happen. Someone wakes up one morning and goes, oh, my back. But oftentimes they've been injured and they've been ill and they continue to say they are ill and they fake being ill or injured even though they are not, and for the specific purpose of that secondary gain. So the specific purpose of malingering is whether it's a financial secondary gain or it's attention, or it's caring, or whatever it is, but they are getting something out of it, and that is the reason they are faking their symptoms, okay? And it's really important to have that knowledge, because factitious disorders are when a person makes themselves ill, but with no obvious external reward. So malingering, there's an external reward, whether it's financial or whether it's emotional, it's attention, it's services, it's something. With factitious disorder, these are people who make themselves sick, but we don't see a reason why. They get no benefit from it. What you guys have probably heard about before is a variation of this, which is known as Munchausen syndrome by proxy, which is when people, often mothers, make their child sick for no obvious gain, but they actually deliberately make their child ill, in part so they can then be seen as the caring, doting parent who's by their child's bedside in the hospital. And what happens is when medical staff start to think that maybe there's a chance that the mother, again, it's typically the mother, it could be the father though, but it's typically the mother, is interfering with the child's care and actually making the child sick, they will come up with a reason why the mother is not allowed in the hospital for 24 or 48 hours. The child miraculously recovers and has no symptoms, and that's when they go, hey, mommy was doing this. So again, there's no obvious gain other than attention, but these are people who I think we would all agree from a mental illness perspective, there is something wrong if you are deliberately making your child ill in order to get some sort of gain yourself. In terms of where all of these somatic symptom disorders, including malingering and factitious disorder and Munchausen disorder by proxy, show up, they show up to medical doctors. It's very rare for a psychologist to get a phone call of someone saying, hey, I'm blind and I don't know why, so I want to talk about it. Let's talk it out. That happens only once the physicians go, there is absolutely no medical reason for this and we're referring you to psych because we don't know what else to do. So with all of these different disorders, people are more likely to show up to medical doctors. Medical doctors, of course, doing their job properly means assessing, running diagnostics, following up with the patient. So it could take months or even years before a medical doctor arrives at the conclusion that there is actually nothing functionally wrong with them from a medical perspective, but a psych referral is required at that point. And at that point, the person it's been going on for so long that they're very reluctant to say, oh no, this is not, to endorse that it could all be psychological, right? Because at this point, they've bought into it. In terms of treatment, SSRIs tend to be helpful in large part because of comorbidities. Remember I said at the very beginning that it's thought that these disorders do stem from some sort of major stressor or anxiety. So using some of the medications that are used to treat anxiety and depression, because again, somebody who now is 1, 2, 3 years into having a medical problem with no perceived cause, it might very well have fallen into a depression as well because they're feeling hopeless, they're feeling helpless, they feel like people don't believe them, they don't know why this is going on. So we see that SSRIs can be helpful if we're treating the comorbid depression or anxiety, we might see some of the somatic symptoms remit as well. Otherwise, we use cognitive behavioral therapy to, first of all, change the way the person thinks about their symptoms. So that first example, that tennis player with the knee pain, it's like, okay, well, I understand that you're still experiencing some discomfort in your knee. Could that be a reminder to you not to overdo it? Could that be the reminder that you have to be a little bit more careful in your body movements? Can you think about that as when you start to feel that discomfort, maybe it means you need to go stretch, or maybe it means you need to go to a yoga class, or maybe you need to just go soak in the tub until the pain goes away and then carry on with your day. So changing the way, instead of thinking, oh my gosh, I have some knee pain, it must mean that I did terrible internal damage to my knee. It's just like, hey, slow it down a tiny bit. And then also we use cognitive behavioral therapy to change the behaviors of playing the sick role. So a person who has been legitimately ill for a while, or who has been ill with something that to them is very legitimate, even though there's no medical cause, will have gotten used to other people taking care of them, helping them out, maybe having friends come over instead of going out because it's too hard to walk. And they get used to playing this sick role. And people, again, we all exist sort of in balance. If that's what we've been doing, that's what we're comfortable with. We don't try to change it that much. So here we work with also the people who are close to the person in question to reinforce the person when they are not playing the sick role. So a friend calls up and says, hey, do you want to go out for dinner? And when you were ill, you would say, oh no, like I can't possibly walk from my house to the car and car to a restaurant. Why don't you just come over and we'll order skip? The friend is told, don't accept that anymore. Don't come over. If they don't want to meet you at the restaurant, then you'll see them another time. And if they agree to come to the restaurant, then heap praise upon them, right? So praise them for the behavior we want, which is getting out of the house. So that's where we start seeing that encouragement for the person to no longer play the sick role and for the associates of the person to encourage them and to support them in actually doing things and reinforcing the non-sick behavior. This takes us to reflection question number 2. What do you think is so we're sort of taking a step back here to factitious disorders. What do you think is underlying factitious disorder? So remember, factitious disorder is when you make either yourself sick or your child sick for no clear benefit. So what do you think is underlying it and why? Okay, so now we're going to shift gears and talk about the dissociative disorders, which again, I want to reiterate that while they are very interesting, they are quite rare. And again, to remind you that we're talking about the fact that a person's perception or experience of self is altered in a dramatic way. Okay, so the first disorder we have is actually kind of what used to be 2 different disorders, or they're sort of in the old DSM. We have depersonalization, derealization disorder. So whereas before we talked about depersonalization and derealization as different things, they're still different things, but they're in one disorder now. And so the feelings of depersonalization are so severe that they dominate the client's life and prevent normal functioning. And what I mean by depersonalization is repeated experiences of feeling detached from his or her own thoughts or body. Okay, so there is no disturbance of memory that happens here, but it's a sense that like you are not part of your own thoughts or body. So it's almost that thing that we see sometimes in like TV or movies where the person is floating outside of their body watching themselves. That's depersonalization, derealization. So we're not really real anymore. We're not really part of our person anymore. We're watching from either above or from the corner. We're watching as we do things, but we don't feel like we're quite a part of it. So it's a sense of being outside of one's own body and watching oneself. And your voice can also sound strange. Now, our voices always sound strange. The voice that we hear in our heads when we're speaking is different from the voice we would hear when we're watching a video. So for me, this semester has been sort of interesting because every time I get sent the video links for these and I go to preview it, I like watch the first 10 seconds. I'm like, I can't stand hearing myself or seeing myself. And I just post the link. I make sure it's the right thing, right? It's just that double check. But this would be like really radically different. So I know what my voice sounds like in my head, and I know I've seen myself and heard myself enough times because as part of clinical psychology training, you go through lots of periods of videotaping your therapy sessions or audio taping them and then reviewing them with supervisors. So I know what my voice actually sounds like. If I suddenly heard myself like sounding like an Alvin and the Chipmunk character, I'd be like, ooh, that's not my normal, right? And that might be depersonalization, derealization disorder. Dissociative amnesia. This features the inability to recall personal information, usually of a stressful or traumatic nature. So when a person has dissociative amnesia, they cannot actually recall something, usually of a stressful or traumatic nature. And there's 2 types essentially. We have generalized amnesia and then localized or selective amnesia. Generalized amnesia is when we're unable to remember anything, including who we are. Localized or selective amnesia is the more common type, and it's a failure to recall specific events, usually traumatic, during a specific time period. Okay, so it's only during a specific time period. So for both generalized and localized or selective amnesia, the memory often comes back, often, but not always. But particularly for localized or selective, it's going to be just for a specific event. And I want to just sort of jump ahead a little bit to say this is going to be something important to remember for our last class when we discuss the book Missoula. So when we talk about Missoula, when you read it, which some of you by now have probably started it, and if you haven't, here's your subtle reminder that you might want to get on it. And you'll remember, of course, that I already told you, I mean, it's the subtitle of the book, that it's about rape and sexual assault in a college town. So this isn't surprising, but one of the things that we'll see through that book is how people who have been raped are treated by the justice system and by police officers in particular. And if we know that people sometimes will have localized amnesia, a failure or an inability to recall personal information, usually of a stressful or traumatic nature, and that sometimes the memory does come back after a period of time, boy, that makes us really question how we're going about treating people after they report being raped. So hang on to that. That we're going to not focus on our discussion that much this week, but hang on to that little nugget for when we talk about Missoula, because this comes up again in there as well. Okay, our next dissociative disorder, which again used to be considered its own separate disorder, now it's viewed as a subset of dissociative amnesia, is my personal favorite of the dissociatives, and it's dissociative fugue, mainly because I just like saying fugue. It's a fun word. But it's also a very interesting disorder. And this is the one that, again, I've never seen in real life, but I think every soap opera I've ever watched has had at least 7 characters experience a dissociative fugue. And a dissociative fugue is when an individual becomes amnesic, so they have the inability to recall personal information, and they travel away from home and assume a new identity, with no ability to recall the past. Now, eventually, they will recover to their old self with no memory of their fugue state. Okay. So, this example was a lot more salient when I was first at MRU. I'm coming up on 10 years at MRU, so it's a little harder to believe that my fugue state has lasted this long. But how do you know I'm really who I say I am? So you all think I'm Carrie Scherzer. You all think I'm a clinical psychologist, that I'm a licensed psychologist in New York State and registered in Alberta. But how do you know for sure? Like, maybe I just woke up one day in Calgary and was like, oh, like, who am I? And I looked around at my meager belongings and I saw some psychology textbooks and I saw some information from Mount Royal University. And I saw the name Carrie Scherzer, and I was like, oh, I guess I'm Carrie Scherzer, and I guess I must teach psychology, and I guess probably at this Mount Royal University place. And so I came here, and I went to go get at the time, my campus card. Now it's our R1 card. And they said, who are you? And I said, I looked at my contract, and I said, Carrie Scherzer. And they issued me an ID card. So now I have essentially government-issued ID, because even though we are a university, not a direct government agency, sometimes you can actually call a university campus card government-issued ID because we are, anyway, affiliated, funded in part by the government. So now I have something official that has my name. So now I'm like, in the meantime, I've Googled Carrie Scherzer, Mount Royal University, and I see that she's an associate professor in the psychology department. So I ask around on campus, where's the psychology department? And they're like, oh, the EA building. I'm like, EA? Like, what? And they're like, oh, that building over there. I'm like, oh, okay, thanks. And so I go into the office and I go, hi, I'm Carrie Scherzer. They go, oh, Carrie, it's so nice to finally meet you. You're the new hire. Great, let's show you to your office. So now I'm taken to this office. I'm like all legit. I have an ID card. I have keys. They tell me I'm a professor, and all they need is my banking information, and they'll start paying me every 2 weeks? Okay. Well, not every 2 weeks, twice a month. But I'm down with that, right? So now I'm Carrie Scherzer, PhD, psychology professor. In the meantime, my family in New York State is like, where did mom go? I got like 5 kids running around, right? No, okay, I'm kidding. Where am I? Maybe I'm in a 10-year fugue state. Maybe one day next week, I suddenly realize that really I'm supposed to be in the US, but I don't want to go there now, not with what's going on there. But that's literally what happens. The person takes on a whole new life. Now, usually, it would not be something like becoming a professor. It would be more like going to work as a line cook in a restaurant, something that you don't need formal identification to get a job, wink, wink, nudge, nudge, right? Like something where you can get paid under the table. Maybe I become a nanny, something where I can make some money and build up a new identity, but like, oh yeah, no, I don't know why I don't have a driver's license. I think I lost it when my wallet got stolen, right? I developed this whole new personality, and then one day I wake up and I'm like, what the hell am I doing in Calgary? Like, I live in Potsdam. And I pick up and I get myself back to Potsdam, and you know, my husband looks at me and goes like, you've been gone for 10 years. What's going on? I'm like, oh, yeah, I don't know. Anyway, what's for dinner? Right? And just like pick up where you left off. So something we see quite frequently in TV and movies, something we see quite rarely in real life. Okay, reflection question number 3. This one's going to make you think. Imagine that people who experience dissociative fugue were able to choose to remain in their fugue state or return to their old life. Which do you think you would choose and why? So take a minute to reflect on that. Okay, and then our final dissociative disorder is the one that you've all been waiting for, dissociative identity disorder. Now, of course, this is the disorder that is formerly known as multiple personality disorder, and the one that most psychology students, when they first start in first year, they're like, I can't wait to learn about this. And here I am now, you're in 4th, 5th, 6th, whatever year, and I'm going to tell you, I'm not going to tell you that much about it. The person has at least 2 distinct personalities or alters. So we diagnose this when the person clearly has at least 2 distinct personalities or alters. The person that they are, that's like the host, for lack of a better term, and then they have at least one other personality, but usually they have quite a few more, who at various times take over who they are. It is thought that dissociative identity disorder develops through exposure to a significant trauma. And so oftentimes one of the alters is the child or teenager, like at that age that the trauma happened. There's often an alter who is kind of like the protector, the person who's running the show, who decides when different alters come out. The reason people with dissociative identity disorder end up in treatment is either they come in for a comorbid condition, for depression, or for substance use, or anxiety, or they come in because they're like, I don't really understand what's happening. Like, I keep meeting people who call me by a different name, and I keep finding receipts for things that I haven't purchased in my house, and I'm just worried that I'm going crazy. And it's through that process of discovery that we discover that, in fact, they do have alters who go by different names, who wear different clothing styles. There have even been cases where the person needs glasses or contacts and the alter doesn't. We sometimes have alters that are of the opposite gender, so it could very well be that you're female and you have a male alter, or you're male and you have a female alter. And this is one of the times where we actually go to psychodynamic theory and psychodynamic therapy for treatment. Hypnosis will often be a part of treatment. While under hypnosis, the therapist will try to meet all of the different alters, and the goal is to integrate everybody into the host person. So for the alters to recognize that they served a purpose, but they're not needed anymore, that the person is strong enough, and to integrate the pieces all together into one person. One of the controversial issues that comes up with this is whether it is in fact a real disorder or whether it's a psychologist-created disorder. Does a psychologist implant a memory in someone of some trauma to explain what's going on? Do they implant the alters? Because not everybody can be hypnotized. You have to be sort of susceptible for hypnotization. So there's some controversy around that. So that's essentially dissociative identity disorder. I'm sure we will talk more about this. Is one where usually I present very little and we talk more about it. So when we meet up for our discussion, I will look forward to your questions and comments. And of course, your Netflix and Amazon Prime recommendations for different movies and shows you've seen where this is represented. And that's pretty much all I got.